Assalamu alaikum. I think Dr. Asmaa has some technical issue. First of all, I would like to thank all the organizing committee for the invitation. It was a pleasure to be here and to participate in this great event. So we have to my task today to talk about the cold snare polypectomy. It's a debate between the standard of care. So you have to get at least some of the evidence of the how to resect the polyp, how to remove it, what's the purposes. These very important guidelines, as you see, this is a European endoscopy of the guideline and also the British Society of Gastroenterology. They have clear stated that the standard of care is still as a hot snare. Cold snare can be used for 5 millimeters polyps, and also from 6 to 9 considered to be removed by cold snare, and hot snare is still to be removed for large polyp. But I will show you some of the evidence now. Cold snare become one of the new technique to be used in our daily endoscopy or removing the polyps. So is it cold or hot? So we have to have at least the size of the polyp, and you have to select the hot or cold based on the location of the colonoscopy. They prefer to have a distal colonoscopy, a cold for large polyp, and proximal right colon usually cold, and also it can be an AMR. Choosing your snares depends on the lot of factors, but this is the common practical. Usually they prefer the small 10 millimeters and 15 millimeters, smaller and thinner stiff snare to remove all polyp, or you have to get it one end block. Now, why you have to concern about the techniques? It is very important. So endoscopic, sorry, there's a mistake in the spelling here, as I apologize for that. So the resections of the polyp is very important. Why? Because the incomplete resections will lead to a residual adenoma, and eventually you will get a recurrent adenoma. And with the follow-up of many years, from 9 or from 6 to 9 years, you will have internal colon cancer. So one of the commonest cause of internal colon cancer, incomplete resections of the polyp. So that's why we choose the best technique to remove the polyps. So cold snare, as you know, complications usually related to the diathermy effects. So cold, no diathermy. So and the guideline, as I stated, that the European guidelines, they clearly stated that 5 millimeters can be removed by cold snare, and also if you have a polyp around 9 millimeters, it can be removed by the cold snare. Some of the issues of retrieving the tissue is almost around 7%. Difficult to retrieve the tissue. Is very important to know the histology. Also, the addition to that, the cold snare is very easy. You can have a quick procedure. You get the accessories, no diathermy. You can remove the entire polyps. You can minimize the effects or adverse effect of your procedure. As it's mentioned, that also it can be diminutive polyps or 9 millimeters. Even larger polyp can be removed by cold snare. Also, the pathologists usually they need to have a clear margin of the tissue or the polyp. So very important to have a clear margin. With the cold snare, usually they recommend 1 and 2 millimeters around the polyp to be removed. So you have to have a clear margin. Comparing to the hot snare, this is the issue. So the issue of the cold snare, only the risk. So still they have adverse effects, increased risk of delayed bleeding. I know you will say that the cold snare have a bleeding, but usually this intra procedure you have to see it, and then you can control it. But this is something delayed bleeding. Usually it will be late bleedings. Then high mortality sometimes came from those delayed bleeding. Perforations, because you have a very effective diathermy to the musculoskeletal propria, so the perforation still is there. With cold snare, there is no perforations, and you will see the evidence now. And also, most common, usually patient presented by abdominal pain, nausea, vomiting, and fever, and turn to be as a post-polypectomy syndrome. This one of the evidence. You see sometimes a little tip of the polyps or a remnant at the base of the resections. So this is not related to anything. It's not related to the mucosal defects or any vascular structures, or also it's not a remnant of the polyp. and usually there is no any adverse effects of those polyp. I will show you some of the imaging later on. Comparing the cold snare to the cold forceps, as same as cold snares is better than for cold forceps. But if you have a very, very small polyp, around 1 or 3 or 4 millimeters, sometimes also cold forceps can be used. And you see here is a complete resections around 96%, also 93%. This one of the study also give us a clear more than 1 centimeter can be removed by cold snare. The residual or recurrent adenoma was found almost 9% or 10%, and also there is no any single adverse effect of those patients. So now we are beyond the guidelines. So 1 centimeter or 10 millimeter can be removed by cold snare. This is one of the systemic review and meta-analysis of the 8 studies, and we're almost more than 500 polyps. The size almost around 17.5 millimeters. As you see, the adverse effects is getting less, 1.1, and also the bleeding is higher there, 7%, but can be controlled, and it depends on the larger or large size of polyps. No delay bleedings and no perforations, and the resection was completed by the 99%, and this is our aim, to have a complete resection. Without any incomplete resection, you will have a risk of cancer. And the overall residual tissue is around 4%, so comparing to the other, it's almost the same. This is another also meta-analysis give us the efficacy and safety of the cold snare. 10 studies, a high number of patients, almost 1,700 patients, is almost the same. The technical success is almost 100%. The adverse effect is less than 1%. And they recommended that they concluded the study is almost safe and effective technique for serrated polyps more than 10 centimeters. Just I want to show you one of the videos here. As you see, this one of the techniques you have to use. You have to, at least you have a clean colon. You have to put the lesions at the 6 o'clock of the procedure, and you have to place the snare with the normal tissue, and you have to grasp at least 1 or 2 millimeters of the normal tissue to have a clean margin. Now, as you see in this pictures also, so then clearly the lesion at the 6 o'clock, because the channel of the scope is around 6 o'clock, and easy to have the instruments out of your scope, and you can resect it. Then you have to be in around the polyp. You have to grasp at least one of the normal tissue. Once you remove the polyp, then you have to inspect the area of the resection. As you see, this is what I'm talking about. This is the protrusion. This is almost normal. It's not a remnant of the polyp, or also that's a vessels or something seriously like a perforation. What we have to consider now, so I will just conclude about many things in the cold snare. So cold snare now is an emerging procedure in our daily practice. We have to consider the size of the polyp. The recommendation is still within less than 10 millimeter, but as you see, a lot of evidence give us a clear evidence. You can resect the patient, you can resect the polyp with those patients with more than 10 millimeters. And some of the evidence, even they are doing the EMR with the cold snare. Number 1. Number 2, you have to inspect the area. If you have a bleeding, you have to consider, this is the early bleeding, you have to control it. So better than delay bleeding. Risk of perforation is very small or maybe none, because you are having superficial and you're getting above the musculus propria. Then one of the things you have to consider also, you will not use any diathermy. So these indications very clear. And when you have to consider the patient for cold snare, you have to tell the patient sometimes we resected the entire polyp and you have to follow your patients. I think this is the summary. I conclude this talk and happy to receive any questions.
Thank you, Dr. Abed. كنت عايز أحكي بس سؤال صغير. الماجنيفيكيشن بتاع البوليب لو احنا هنشوفها او النارو باند ايميجنج بيأثر على الاختيار بتاع الكولد سنيرنج او الهوت سنيرنج؟
So if I get my questions, so if you use the advanced imaging, it will affect choosing the snare. I think it's not related. Usually, maybe the type of the polyp is as we mentioned in the presentations, it matters, but most of the evidence now, serrated or adenomatous polyp, small size polyp, it can be removed by cold snare. So I know you point to have a more assessment of the polyp or maybe the more characteristic of the polyp, but it clearly stated that you can remove even serrated more than 1 centimeter, and you can remove adenomatous more than 1 centimeter also. But the recommendations, they still less than 10 millimeters can be removed by cold snare.
Thank you.
Are you have more questions? So now we'll give the mic to Dr. Asmaa to talk about the hot snare.
Professor Abed. I have a question for you, Dr. Abed, please.
مساء الخير. This is Dr. Asmaa Kandary from Kuwait, and I would like to thank Dr. Abed for his nice presentation. But I want to tell him that if you have tea, you want to drink it hot or cold. Hot, cold is still, we have cold iced tea, but we still prefer the hot tea. في أحد يشرب الشاي بارد؟ So EMR is hot or cold? This is our beat. We always competing with the Saudi Arabia by football. This is the idea of Dr. Mohammed. طبعا من سنة 80. I just want to start my topic about endoscopic approach to any GI lesion. Like complexity is usually you have to assess your lesion carefully about the size of the lesion, morphology, location, where is the lesion is on the right side of the colon, left side of the colon, and the patient condition. Always remember, you're treating patients, not polyp. This is an LST granular, mixed granular lesion in the rectum. And such lesion, you have to assess carefully before you attempt to resection or decide what you have to do with this lesion. Either to go for EMR, ESD. And I usually recommend all the people, all the gastroenterologists, just to do like this is a chromoendoscopy. And now with the new technology or new era of the artificial intelligence and virtual chromoendoscopy, we start using MBI, BLI, LCI, which give us really a good picture about what you are dealing with. Such lesion like that, I don't think anybody will attempt to resect lesion like that. This is a T2 from like, we tried to lift it, there was no lifting. And you see that the periphery looks like benign. If someone attempts to take biopsy from the periphery of the lesion, it looks benign, but the center, it's deep invasion. Techniques for colonic lesion, like we have polypectomy, simple polypectomy, endoscopic mucosal resection, and ESD. Like the endoscopic mucosal resection, the EMR, we have like the cold snare EMR, injection assisted EMR, cap assisted EMR, and ligation assisted EMR. I always love to inject any lesion above 10 millimeter. Why? Because lesion demarcation really identify the border, and you can see that the border very clearly, and you achieved like a full resection or not. And you can evaluate the lesion by injection, like if it's lifting or non-lifting. Although there are 20 to 30% of SM2 and SM3 is still lifting with you, but it gives you a clue. Lesion presentation, like you have to, like such lesion behind the fold, you can inject like behind the lesion just to bring the lesion in front of you. And lesion elevation really prevent the side effect, like as Dr. Abed said, the deep thermal injury, which can always be your worries when you do hot snaring. And always I recommend to inject like using 30° by injecting the needle. You have to inject like the submucosa, not in the muscle like the second pictures. Like you have to just when you insert the needle, you should put it in 30°. This is the EHGC guideline. Like I agree with Dr. Abed, anything below 10 millimeter, it can go for cold snare polypectomy, but more than that, is still for hot snaring. Like 10 millimeter, 10 to 20, it can go for hot snaring polypectomy. More than 20, it needs like further evaluation to look for any sign of invasion and decide either for EMR or ESD. Like this such lesion, if you look at it, it looks like, you feel it's like serrated lesion, but with the using of the optical diagnosis, we find this is adenomatous tissue using BLI and MBI. And here I use the BLI and LCI and checking the lesion, examining it very carefully, try to lift the lesion. We are injecting, as I told you, like using 30°, and try to elevate the lesion as whole. I think this is with adenoma. If we try to just take the lesion by snaring, it will cause really bleeding, and you can't identify the edging or oozing, because the risk of bleeding for any adenomatous more than 10 millimeter, it always carries high risk of bleeding, intra-procedural bleed. Like such big lesion in the rectum, almost circumferential, with a strip of normal mucosa, I don't think like you can attempt removing such big lesion, almost 90% of the rectum, with standard cold snare polypectomy. Like the adenomatous tissue per se, it carries high risk of bleeding, and if it's in the rectum with all these hemorrhoidal plexus and the vascular supply, it really carries high of risk of bleeding, and it will. If you just start doing attempt cold snaring polypectomy, I think the field will become very messy, and for sure you will leave some residual behind. That's why you just look at the lesion, identify where you want to start from, right, left, right, anal side, rectal side, and just go circumferential, like bit by bit. And this is the last bit was remaining, and we remove it by EMR. And the aim was just to leave a strip of the normal mucosa to prevent the stenosis. And the game is still between me and Dr. Abed. It's going between Saudi and Kuwait. But I can say that hot still hot. Like even with the SCAR study, we're still using the heat to prevent the recurrence. Even with the polypectomy or any polypectomy or resection, that this prospective multi-center RCT trial was conducted by Sydney Group, showed that control versus snare soft top coagulation using 80 watt and effect 4. The primary endpoint that they showed that the soft tip coagulation reduced the recurrence from 20% down to 5.8%. That's with hot snaring even. And this is a very example of another polyp, which is, you can see it's vascular. And I don't know how you can attempt removing such lesion, which looks really vascular, adenomatous tissue with cold snaring. And it's more than like 10 millimeter. Like, as I told you, have to have good elevation to prevent the adverse event, like what Dr. Abed said, perforation, bleeding, and post-polypectomy syndrome. That's our worry always with hot resection. This we take it en bloc and we remove the lesion. Then you can just assess the site of the resection. And this is such of lesion that we can't go with cold polypectomy, because pedunculated polyp, and always the pedunculated polyp, it has a feeding blood vessels, and always our worry with this bleeding blood vessels. Even with the hot snaring, as you can see how the blood is just spurting. Here, definitely we need heat. By using the co-grasper, localize the area of the blood vessels and catch this blood vessel and coagulate it. What about underwater EMR? There is a rule for EMR, like underwater with hot snaring. It works really well, and there is a sufficient data to support that, especially for recurrence, polyps, fibrotic base. It works really well, where you can inject underneath, lift the lesion, and start resection. As I told you, we start resection by putting a plan in our head where to start, like left or right from the anal side or rectal side, and we start sequentially, like bit by bit. If we start from the right, we go to the right until we reach the left side. This is a meta-analysis, a review which published showed that the underwater EMR significantly lower rate of the incomplete resection and residuals, reaching R0 resection, especially for polyp more than 10 millimeter, and the rate of en-bloc resection, delayed bleeding and perforation, and post-polypectomy syndrome were similar in between the group of underwater and non-water. What about cold snaring? We really have a lot of data, but most of the promising data there was about the polyp less than 10 millimeter. And there is also a cold snare that this is what Dr. Abed said. There is a meta-analysis which was published recently, all showed that this is possible for more than 10 millimeter, but the recurrence rate were higher in polyps more than 20 millimeter and adenoma, 11.1 as compared for 1% for sessile serrated polyp. And all the lesions were resected by cold snaring polypectomy, like more than 50% they were published, but more like all the published data, they were including more than 50% of the polyp, they were sessile serrated polyp. The complication that we were talking about, like the adverse event after EMR, we always worried of the bleeding, perforation, strictures, and bleeding is the most common. And inter-procedure bleed rate after EMR of any follicular large lesion reported to be between 11 to 22%. Like such spurting blood vessels, we really need heat to stop this bleeding. It won't stop by itself. Like co-grasper is really, and Dr. Mohammed Sherbini said, like our hot biopsy forceps. Like heat here is mandatory for us. Like we cannot work without our diathermy machine. And this is our worry, like the complication and the perforation after EMR almost like less than 1%. The safety, like you have to recognize if you have any perforation, you have to recognize it early. Bleeding, you have to just work proactively without even saying. You have to have a good team working with you. You know what you want. At the time they see the bleeding, they have just to run, bring the co-grasper, change the thermy to the soft coagulation. And you have to know this, the post-polypectomy syndrome. The patient come with fever, abdominal pain, high CRP. If you did like the imaging, you will not find anything. The end of our game. I agree, cold polypectomy for less than 10 millimeter, cold EMR, it works really well for sessile serrated polyp, but hot resection for adenoma more than 10 millimeter, any suspicious lesion or high-grade dysplasia or suspicion of cancer or invasion, ESD or en-bloc resection. EMR is efficient technique to resect superficial neoplasm with low recurrence rate. And what we need is an RCT trial comparing hot versus cold resection. Kuwait and Saudi, they are forever together. Thank you so much. I would like to thank my team. They are really great support for me back in Kuwait. Like this is Dr. Raed and all the nurses. They are really, we're working as a one team. Thank you so much.